Hey everybody, welcome back to the ECG channel. My name is Reed, and before we get started on this video, feel free to head down to the description and download the PDF of today's ECG so that you can follow along and make your own notes. And feel free to like this video to help support our channel and subscribe if you want some more. So let's jump into it. So the first thing I like to do is look at the forest, and the trees of the forest are my QRS complexes. And so my pick lead 2 here, I've got a narrow complex rhythm that seems to be in this kind of pattern of group beating. Right, we see like group of twos with pauses in between, right? And so we have kind of this pattern of 1, 2, pause, 1, 2, pause. You can see that goes throughout the entirety of the rhythm. And so group beating should make you think of two things, either a second degree AV block or some type of premature contractions, premature beats, right? And so let's evaluate this rhythm for some of those things. We see we've got some P waves here, so it seems like this is driven by the atria in some way. And so yeah, let's jump into it. So let's evaluate our P wave morphology. What is the atria doing? And so I'll pick maybe the first in our bigeminy. And so we've got P waves that are upright in lead 1. They're upright in AVF, and so these are sinus P waves. And then when I look at the second P wave, it looks like it's almost very similar, but if you scan through, you see that there are some small subtle differences in some of the amplitudes of the P waves, right? If you look here in maybe V2, the sinus P wave is a little different than that second P wave. Is a little bit more, it's just different in amplitude by just a hair. And so we'll kind of just go through algorithm and then we'll suss out what these beats could be. What's the AV node doing, right? We need to determine, we said this could be from a second degree AV block. When I look, I see that my PR interval is in between. My PR is in between 120 to 200 milliseconds, so that first PR interval is good. And then I see my second PR interval seems to be good, just about the same. And then now I need to make sure that there isn't like a third P wave. We need to make sure there's not a third P wave that is not being conducted, right? Because that would tell us that maybe there's a second degree block. And so I'm looking through, and I don't see a third P wave that's non-conducted. So I don't see a third P wave. So that makes me think that if I measure the first beats of the group beating, if I measure their intervals here, that my next QRS should land kind of right in the middle. But this one comes early, right? We've got an early beat. And that early beat has a P wave associated with it every time, right? We see these P waves. And the P waves are so similar to the sinus P wave, but they're just a little different. So what does that tell me? That tells me that because they're so similar, our normal P wave axis is because the sinus node fires and depolarizes the atria. Well, we could have a premature atrial contraction that comes from an area just next to where that AV node is, and have a very similar wave of depolarization. So that could explain why these, which are premature atrial contractions, this might explain why they're so similar in morphology. Usually we see grossly different P wave morphologies. These ones are very, very, very similar. But we know they're premature, and we know they're atrial because the QRS is the same. And these are occurring in every other beat type of pattern. And so this is atrial bigeminy. All right, so we've got atrial bigeminy. And now let's evaluate the QRS, right? And so the QRS, we can see the complexes are upright in lead 1. They're isoelectric, just a little bit negative in AVF. So my axis is just a little bit away from AVF. I would say somewhere kind of in this region, most likely. So left axis shift. It's okay. You can see we've got little R waves here in V1, and they seem to progress maybe a little bit early. maybe a poor lead placement sometimes, depending on the patient and their chest wall anatomy. When you see V2 is higher in amplitude than V3, you kind of think maybe they put this in, that those leads in the wrong orientation. That's okay. And then we're going to look at our QT interval. In the QT interval, sometimes you just kind of look at the QT, make sure it ends at least midway between the R to R intervals here, which I think they do an okay job with, especially in the setting of a premature beat. So then I'm going to look for pathological Q waves and ST and T wave changes. Luckily, I don't see any. And so let's put this all together. This is a pretty simple one. So we've got a sinus rhythm, our rate. Let's calculate our rate now that we've kind of figured out this is a bigeminal pattern. What you can do is you can take these, since you can't really measure here to here, that wouldn't be the best. You can actually measure from this R to this R. You can calculate the rate of that and then double it. And so let's see, we've got how many little boxes? 5, 10, 15, 20, 25, 30, 35, maybe 39 or so little boxes. So 39 millimeters. So one way that you can calculate the rate is you can do 1500 divided by the little boxes, so 39. And so if I do 1500 divided by 39, sorry, I'm doing this in real life, is 38 beats per minute, but we need to double it. And so times 2, that is going to be 76 beats per minute, right? We have to double it because we're measuring 2 QRS durations. So we have a sinus rhythm at a rate of 76 beats per minute, and we have premature atrial contractions in a pattern of atrial bigeminy. So I hope this helps, and if you have any questions, throw it in the comments. And if you enjoy the content, think about subscribing to the channel so that you can help grow and expand our reach to other learners. And yeah, thank you so much for watching. Have a great day. See you tomorrow.